Thank you all for being here. I appreciate knowing where you're from. That's helpful. Our next speaker is Christie North. She works for HealthInsight. She is the Vice President of Utah Programs. She's also on the advisory board for the University of Utah MHA program. She's worked in healthcare for over 30 years as a consultant and also in management in Intermountain Healthcare. 3 years ago, she got to begin what she considers the pinnacle of her career, the executive director of the IC3 Beacon program, and that's what she's going to be talking about here today. Christie.
Thank you. You know, I've been listening to all of Heidi's introductions today, and I thought, God, these people all sound so great. She even made me sound great, so that's good. I first want to thank Heidi for inviting me to be here. This is really very interesting for me. And there was a gentleman here earlier today who asked a question. I hope he comes back because I have the answer for his question. We'll talk about project managers and how important they are in healthcare especially. And this is the pinnacle of my career. I want to thank George Bush Jr., because in his second term he signed the High-Tech Act, which made Beacon possible. I'll tell you a little bit more about that in just a minute. So what do I think I'm going to tell you, and what I hope you'll walk away with, is how is it that Utah came to be in the running to even get this cooperative agreement, $15 million actually, and how we benefited from having a project manager on our staff, and then what are the long-lasting effects of having the Beacon come to Utah. So with that, a question was asked earlier today about, well, actually Nick asked during lunch, is it not conceivable that healthcare could operate as a cash business? And I told him no, because most people aren't willing to pay cash for it. There's this belief that the only way to pay for healthcare is with insurance, which is a bit of a challenge because it really hasn't been that way that long. It's been that way for about the last 40 years. But before that, people paid cash out of pocket for their health care. It's a lot more expensive. I'm not suggesting we should all go back to that cash basis, but it's no longer conceivable because people believe they need to have insurance, and they equate that with health care. This weekend, Don Berwick, who was the interim leader for CMS, the Center for Medicare and Medicaid Services, for a couple of years, and then he was never confirmed, so he left. He was on a panel with the Dalai Lama. I wish I could have been there. Two really amazing intellectuals. It would have been fun. But they asked each of the presenters to tell the Dalai Lama a little bit about where they are in their work world, and then ask a question. So Don Berwick said, there are 3 myths that many people operate within in healthcare. 1, more is better. If you argue with them that more is better, they immediately say, you want to take something away from me, and make it a very bad thing to say more is better. More is not better. Health comes through healthcare, which is a little bit like equating getting healthcare with getting insurance. As Mark showed earlier this morning, health doesn't come out of healthcare. Recovery comes out of healthcare. Health is something that you really do have to do for yourself, but then people will say, you want me to change what I'm doing? And then the third one is, one can separate body care from mind care. Don Berwick believes this, but many people do not, because what they say is, well, you just want to blame me. You want to say that it's my own fault I'm sick. So you can put a twist on anything you say. So Don Berwick turned to the Dalai Lama and said, so how do we address this fear so that we can get change in healthcare that we need? And the Dalai Lama said, you must educate the people. Well, Don Berwick has been educating people for his entire career, and he's a pediatrician, and he continues to educate. So he's got job security. I don't. The point being, George Bush gave me a 3-year job, and now I have to figure out what I'm going to do when that's over. So high-tech was the law that George Bush passed in 2009. And at that time, he created the ONC, which is the Office of the National Coordinator for Health Information Technology, and passed the High-Tech Act, which allocated about $20 billion to making sure that healthcare was electronic, that there was a nationwide network of health information systems, so that every provider would have an electronic system in their offices and that they would talk to one another via those electronic systems. He thought that that would guarantee much better health care. A lot of people sort of blame this whole health care thing on Obamacare, but they're not simultaneous. They're not the same thing. They're symbiotic. They work well together, but they're not the same thing. And we really have to blame George Bush for this one, darn it. So in early or late December, HITECH Act made arrangements for the RECs to be funded. And the REC, Wyatt will be telling you more about. Utah has had a community in healthcare for a very long time. So when we heard about the HITECH Act and we said something's going to be coming, and oh, by the way, there's this request for funding opportunities out of ONC, we convened. We brought together all of the key players, the payers, the insurers, the providers, hospitals, doctors, the folks from telehealth, the folks from laboratories and pharmacies and everywhere, brought them together to say, well, what does our community really need? What needs to happen for us to be really successful under this HITECH Act? So the REC proposal was sent early in 2010, and in February, I think, of 2010, 34, I think I may have that number wrong, but nationwide there were 34 RECs, Regional Extension Center. They're patterned after the agricultural extension centers. It was a great idea. Go out and teach people where they live how to do what they need to do. At about the same time, HITECH put out a funding opportunity announcement about Beacon. This was an exciting opportunity for us. We had just applied for the REC, which was how much per year? 5 million? I'll make numbers up, because when they get that big, it doesn't matter. And so our organization looked at this and said, we're pretty sure we're going to get this one. We don't really even want to apply. However, I looked at it and said, oh, this is so perfect for us. We have to apply. So the person who helped us write it said we've got about a 10% chance of actually getting this one. So shortly after that, we sent our proposal in. It was 100 pages with not including the addendums that we had to include, and we had 1 month to prepare it. So we weren't very confident again that we would even get it. REC started in March, I think, after the announcement, and at the same time, approximately, the Health Information Exchange started. Patty Connor talked a little bit about how the exchange of information between providers was the beginning of how healthcare it was being reformed in Utah. So then the New York Times announced 15 Beacon communities throughout the United States are each getting about $15 million. We learned about it from the New York Times. We were not notified at that point in time. But when we were notified, it said, oh, by the way, this started at the end of March, despite the fact that we didn't even tell you until May. So we were already behind. So what did we do? We panicked. And this is especially poignant because at this point in time, our total budget in HealthInsight was about $8 million. And within 1 year, it jumped to $24 million. So we had a threefold increase in revenue, which means at least a threefold increase in the work, because the contracts we get are not cost plus, they are cost driven. So we don't really get an opportunity to make money on them, but we certainly can get the work done. So the Beacon project came to Utah for $15 million, added to the work going on in the HIE, the Health Information Exchange, and the REC, Regional Extension Center. When you write a proposal for a grant like this, or a cooperative agreement, because the difference being a grant, you write it, you do exactly what you said in the grant. In a cooperative agreement, the funding agency has the opportunity to say, yeah, we approved it, but now we want you to do this instead, or do that and this. So there's a lot of give and take, which makes it really interesting because we say the environment's changed, we'd really like to do this, and they have the option of saying, you're right, the environment's changed, do it. And so for me, this Beacon project has been the most exciting thing I've ever done. Playing with somebody else's money is a little bit nerve-wracking because A, it's my money, it's tax money, and I want to make sure it's spent well. I was just explaining to one of my colleagues that we're in trouble with the feds because we haven't spent enough money, which is a crazy place to be. To me, it seems like if we're getting the job done and we're paying less, should be good, but it isn't. So we needed to figure out what had changed in the environment, what do we need to do now, determine what available resources, and not just money resources, but where are the people who already know how to do the things that we want to do, identify the partners that we can work with, and start the work. So first thing I did, I was named executive lead on the same day the New York Times made the announcement. So I was a team of one, and we were supposed to hire up to 14 or 15 people. This was a job creation, sort of a piece of work. So I set about to assemble a team and begin to explain to them what the project was. This is $15 million. We have 3 years to do it, and here are the things we're going to do. And my team began to drop like flies. I had 2 project leaders leave in the first 6 months. And that left me with 1 FTE to begin to do this $15 million worth of work. Freaked me out, needless to say. That was a really scary place to be. So I would like to say that this was sheer genius on my part. In a way, it was a little bit of an accident. But the next thing we did was hire a project manager. This project manager came in the midst of the chaos and said, well, here's the first problem. You don't even know what you're doing. You know, you've got all these pieces of work you want to get done, but you haven't really described how you're going to do it. You don't have a work plan. You don't know what you're going to do. So we brought in a project manager who said, let's get organized before we assemble the team so that we know we're getting the right team in here. So when we did, in fact, make a plan and assemble a team, the team was the right people. And there were enough of them to do the work. And they didn't drop like flies. So that's where I would begin to say a project manager brings a different perspective to the work. You all know this inherently, but the fact is the way we had always operated at HealthInsight, we would take people who were really good at doing whatever they did, whether they were analysts or whether they were project coordinators, which meant they took a lead role in particular projects, but they were always fairly contained and fairly small. We really had never used project managers. Since the time we got our first one, who happened to be Heidi, we have really expanded that role so that we're creating more people who understand what project management means and can create charts that are meaningful to other project managers so that as we try to get things done with our partners, it makes sense. So what I think we got from professional project management was really detailed project planning. I am a big picture person, so I said, okay, well, we're going to do this in the first year, and then we'll do that in the second year, and then we'll do that in the third year. And immediately we started getting some details to those big picture things so that we could actually say, this is your job, and this is what you'll be held accountable to do. Also, the specification of how those things were going to be done, we were able to spell that out. $15 million sounds like a really large sum of money, and in fact it is, but there's still budget constraints. And we had partners who were each getting about $1 million out of that, and we were paying for certain interfaces for about $5 million. So, you know, lots of money out there going to different places. We had to know where it was going and why. We had to keep detailed information about what we were doing with the money. Big timeline demands. There were some activities that were absolutely dependent on others. We needed to understand that. And Heidi brought that to us. And then, as I said before, the team. The other piece is tangible deliverables. What are we going to actually put out that is going to be appreciated by our funding agency, by our community, and by our other partners? Because if we don't have tangible results, we're going to look back after 3 years and say, gosh, that was fun. Thanks for the job. But there wouldn't be any lasting impact. So milestones along the way lead us to that opportunity for high impact at the end. So the Beacon came to Utah, and we had to decide exactly what to do. Well, we had been working on a project to do payment and delivery of health care reform around diabetes. So we had said when we wrote the Beacon proposal, we should do this around diabetes because it's something we understand. It's a huge issue. 8% of Utahns have diabetes. 30% of the dollars spent on health care go to help patients with diabetes. There's a mismatch there. Wherever there's a mismatch, there's an opportunity to help this population get better and at the same time reduce some of those costs. Everybody likes that as long as you don't say, we're reducing costs. And to do that, you're not going to get what you were getting before. People get very excited when we do that. So we focused on quality improvement in 60 clinics, about 350 providers. And this is one area that our project manager had to wing it. And in the beginning said, we think we're going to impact about 22,000 patients. There was a big mathematical equation that went with it, but we think we're going to impact about 22,000 people. We just did a calculation after 3 years, and we've impacted 25,000 people. So that's the absolute right way to go. Guess, and then get better. So that was very helpful. So all of this is being built on a platform of health information technology. It's not a technology project, but it has to be built on technology. Somehow we have to figure out how technology can help us do what we want to do and do it better. So our focus was on diabetes with these 60 clinics. In addition to that, we had a partner at the University of Utah, the Family Medicine Group, who wanted to do some work around care management. They have created a new way of taking care of patients in a team environment and using a care manager and using a care navigator, which helps the patient to wander through the system of being admitted, going to the doctor's office, doing follow-up care, and keeping them out of the hospital again. So an interesting piece, and we're going to have a lot to talk about when this is over because they've done a lot of research quality work. It's not truly a research project. It's a demonstration project, but we're going to get some very good data to be able to share. The Utah Department of Health is a big partner. They had two big pieces in this. One, public health reporting. There are 72 diseases in the state of Utah that must be reported if the condition is found, either through laboratory testing, visits to the hospital, or the physician. So those have to be reported to the Utah Department of Health. Well now, or previous to starting this, those may have been reported by, oh, hey, I've got a patient down here and it looks like they've got hepatitis. Or they send a fax, or they send a letter, or they put it in a stack and somebody calls at some later date. It could take up to 2 weeks to get that notice in. Well, if we're dealing with tuberculosis, how many people could be spread with that tuberculosis in the 2 weeks that it takes to report it? So our idea was, let's do this more quickly. Let's get a direct line from the diagnosis to the Department of Health so that it can then start the surveillance necessary to protect the other people. And then POLST, which is physician orders for life-sustaining treatment. Some people say that POLST forms are intended to withhold care from elderly or sickly people. The fact is, all POLST forms are really intended to do is to make sure that sick, elderly people get the kind of care in their end of life that they want. When people are asked what they want, they almost always say not everything. If they're not asked, they get everything. So there is a clear mismatch there. People want to die at home and they're not. So my colleague Deepthi is going to talk a little bit about that later on. Much better than I'm just briefly touching. So the Utah Health Information Network, that is a nonprofit organization that has been around for more than a decade, and that's not the right word, most of the claims between providers and insurers and the communication back from insurers to providers go through a conduit, and that conduit is the claims administration at Utah Health Information Network. So most physicians are connected to that system. Most payers are connected to that system. So that was a logical place when Utah decided that we wanted to begin to do clinical health information exchange. So a lot of the platform and the foundation were already built at Health Information Network. And so it made sense to try and build this clinical site there. They're our partner for a variety of reasons, but not the least of which is that we hope to be able to measure the care on these 25,000 patients in both claims data and in clinical data. And then finally, Intermountain Healthcare is a partner. And Intermountain Healthcare has for a number of years done a lot of really good internal reporting, and they have something that they call the patient summary worksheet that they have appear when a patient appears, and I say appear on the computer. And they said, I think we can make this better and we can make it available to all providers instead of just Intermountain providers. So those are the partners. Now, in our diabetes work, we picked 8 measures, and we said if we can get all 8 of these measures to move, meaning go from this level to this level, patients will be cared for better, each patient will be healthier, and we believe we can begin to drive the cost of care down because it costs less to do the right thing at the right time than it does to do the wrong thing and then do it right. So we believed if we measured A1C, which is blood sugar, if we measured LDL, which is cholesterol in the blood, if we measured blood pressure, and if we looked at having eyes screened for retinal damage, which is very common with patients with diabetes, did screening of the feet because neuropathy in the foot is very, very common, and kidney screening because kidney disease is linked closely to diabetes. If we can look at all of those things, we think that we will be able to determine that the care has gotten better. So the first line, all of those are screening measures. It is the patient being tested. So those are process measures. We can get that information from claims data. The next 3, however, A1C, LDL, and blood pressure control means that the patient has been tested and is at a level that considers them healthy. If the blood pressure is, who's got high blood pressure? A lot of people. You don't know you've got high blood pressure until the doctor measures it and says you have high blood pressure. So put you on a regimen and measure again. And if you don't have it, then we measure again and again. And if you stay down below high blood pressure, then your blood pressure is in control. Same thing with the sugar, same thing with the cholesterol. So we said we can get all of those in control. Plus, we want to look at the emergency department use because patients who are well controlled in their doctor's office don't end up in the ED, don't end up being admitted to the hospital for diabetes complications. So that is a decrease in services that are not needed. Mark talked this morning about waste. That's one of those pieces of waste, admitting people when they could have been cared for in another setting. And then the reporting of communicable diseases, as I said, and the end of life. So, what did we accomplish? The electronic POLST, which I told you what a POLST is. It's a form that describes what people want in their end of life. The problem with it is that it is a piece of paper, and as such, it can be misplaced. It cannot be with the patient. We heard a horror story recently about a patient who was very clear about what they wanted in their end of life, lived a good life, quite elderly, did not want heroic measures, did not want to end up in the hospital. She went to church with no paperwork and had a heart attack. EMS system was called. She was revived. She has a much lower quality of life right now and is in a nursing home. Something she expressly said she did not want, but because the papers weren't with her, that's what happened. So we determined if it's an electronic paper form, an electronic form, then we can have providers and patients have the conversation about what do you want in your end of life, put it on the electronic system, and it's available down at the other end, no matter where the patient is, no matter if they have the papers. My father lived in California, and they have a very active POLS system, but it's not electronic. So he had a copy in his wallet, in his car, in his bedroom, in his bathroom, in his refrigerator, just in case, and hanging on the wall right inside his front door. Because he said, I want to make sure that there's no excuse for doing something to me I don't want done. So public health reporting, we are getting those reports headed toward UDOH. We are getting them reported. we're still working on the next step, which is taking it out of the health department and getting it to the local departments electronically so that they can start the work. The care management learning is going on at the U. They've done some patient activation studies, and they have found that, this shouldn't be a surprise, but with research you sometimes have to start with what you think you're going to find and then see if it's true, that patients who are interested in their own care, patients who are activated, if you will, actually have better health. They have better results. Their diabetes is in control faster if they show an interest. So the idea is, how do we get everybody interested in their own care? Mark called it the 60 minutes versus 525,000 minutes of everyone's life. Well, that's what it is, because care is not done in the doctor's office. The advice is given in the doctor's office, but the care, you got to go home and do it yourself. I'm sorry. There just isn't any other way to make that happen. So patient summary documentation is going on with Intermountain, but most importantly, we're improving the care, we're improving the population health of people with diabetes, and we are bringing the costs down. I want to just show you a couple of graphics. This is how we report. This is our dashboard on the 8 measures. A1 screening, control, LDL screening, LDL control, blood pressure control, nephropathy, which is the kidney disease, eye exams, and foot exams. So if you look over here, this is a group of 12 clinics that have had extra special effort. We've had clinic facilitators in their offices on a sometimes weekly basis to help them figure out how to change their patient care so that they can get everything in the green. Well, this is just a way of showing that. This is a composite of those 12, but each of those providers get their own scores so that they know that in terms of foot exams, you have met the goal or you have not, and in this case, in nephropathy, and how many more patients you need to get screened or in control to have met those goals. We asked this group of clinics to meet 7 out of 8 of those, and that is a huge stretch. We asked everybody else to improve as many as they could, and most of them improved 2 or 3. Here's what I think is exciting. Group 1 and 2 are big systems. Those are systems who've been doing quality improvement for a very long time. Group 3 are independent clinics, and these are very often single doctors or a doctor and a nurse practitioner or a physician assistant, but they're very small clinics. And the thing I like is, can you tell that there's a whole lot more green on this one? They have made huge improvements. And the other, oh, I'm sorry, not that one, let me see. No, darn, I didn't put it in here. I have a chart that shows where the independent clinics started. So I'm just going to make a graph with my hands. Independent clinics started right here, and they are up here. Everybody else started up here, and they've made a little progress, but the independents have surpassed them. And we think that that's because they had not had access to the tools that we've shared with them, the management tools, the quality improvement tools, the focus on making changes happen. So we believe the big learning here is that big systems aren't necessarily better. They definitely have the resources. Little systems are very agile, can make change happen quickly. And in some cases, that's even more important. So just a couple more graphs. These are control charts and 2 analytical types. Control charts are the holy grail of showing data. And this is just standard deviation. But if you just show this graph, it looks doggone good, doesn't it? All of those are going up, and as long as I don't tell you that they're supposed to go down, that looks like a good thing. And in fact, all of those are supposed to go up, and it is a good thing. But what you don't know is when is it really a good thing, and when is it just these things are kind of doing okay? Well, the control chart is the standard deviation, and that tells you once outside the control chart on the good side, then you have a sustained process change. So what you can see is that we've got 3 above there and 2 there and just 1. We just barely made that one. 3 there, 2 there. And this one is just, I think next month it will be there. So the point being, this doesn't happen quickly because we're taking 25,000 patients and changing how they live their lives. Because it's not just go to the doctor and get your blood test, but it's go to the doctor, get your blood test, and then do what you're told with regard to diet and exercise. And how many of us do that? Not many. All right, one more graph. This is just to show that of the independent clinics and the robust clinics, which was that cohort of 12, they both started relatively low and are finishing relatively high. And what that means in real numbers is that 2,500 people, so a tenth of those that are really being looked at here, have their blood sugar in control. And 2 years ago, they did not. So 2,500 people are healthier today because of the changes that their doctors made in their care. I just want to make a full circle here and say part of the reason those doctors were able to make change is that we had facilitators in their clinics helping them, coaching them to make quality improvement changes, and we had quality improvement coaches in their clinics because we had a good project manager who recognized that's what we needed. So that's how I looped it in to make it fit for you all. So I think that is all I have to share. I'm happy to talk about anything else that you want to talk about or answer questions. Yes?
You mentioned the one about the exchange of the technical information from one clinic to the doctor's office, et cetera.
Right.
Recently, a doctor of my son's had asked for my son to go and get some blood work done. And so he went to the clinic to have his blood drawn, and he said, this is specifically for Dr. So-and-so, can you make sure he gets it? He didn't get it. Is that because he isn't on the network, or was that just a fluke? Or is it,
He didn't get it electronically, or he didn't get it at all?
he didn't get it electronically.
Because there's a couple of reasons, and since I don't know the specific case, I'll give you a couple of my best guesses. A, every doctor must have an electronic health system in their office. So let's assume that doctor has one. But then the next step is every doctor's office must be connected to something so that the information can flow, either doctor to doctor or laboratory to doctor. My guess is that connection is probably not made at this point in time.
It was given to another doctor.
Who might have been in that connection. Or human error. We just cannot, somebody forgot to dot the I or cross the T and it didn't get on the chart. And a lot of people are saying electronic health records don't save money. They make people do more tests because they have so much fun playing. Well, I suspect that may happen in a few cases. Early on, Wyatt is going to refute that when he gets up here to talk to you. I can tell by the cough. But in fact, over a period of time, the care does not get duplicated. So that lab test, hopefully, because it's in an electronic system, won't be repeated in a month unless it needs to be, because somebody can't see it. A lot of times patients go into the hospital and will have an expensive test, let's say an MRI, and that's thousands of dollars. And then they will go see a doctor who maybe is not affiliated with that hospital. And the doctor says, I think we need to do an MRI. And the patient says, gee, I think I had one of those. The doctor says, well, I don't know where it is. I can't find it. I'll just do another one. So another several $1,000s, the inconvenience to the patient to get the same results twice. Well, if it's electronic, the chances of getting that information from the first MRI to the second doctor are much, much better. So we advocate electronic transfer of information so it's not getting lost. So it's not on a paper that is somewhere and if we could just find it, we'd know what we were doing, but is in an electronic system so it's accessible and it is accurate, because electronic systems can do a lot of validation on their own. They can say, do these numbers make sense in the big scheme of things? And if they don't, then they call a person, and that person has to come and look at it and say, well, why doesn't it make sense? Let's see. Oh gosh, everybody we did today had the same birth date, and it's today. Not so good. So then they can get that sorted out so that the results now will make some sense. Yes?
Go back to the lady that had the heart attack at church. Even if she had something around her neck, the EMT, aren't they
Here's the story. Yeah. The law says that without evidence that this patient does not want to be revived, you must do everything you can. You must do everything that you can. What a post form does is it says, here's what I want done. Here's what I want done. If I am found unconscious and my heart's not beating, do not resuscitate me. So that will be the number one thing. So if that form is pinned to the lady's chest when the EMT arrives, they can look at that and say, this lady does not want to be resuscitated.
And they wouldn't do it?
And they would not. They are not required. No, because that woman has gone to the effort to tell people what she wants. Now, should we resuscitate everybody? That's a moral question I don't even want to go into. But she has said, if I die, just leave me alone. Let me have a natural death. Don't do heroic things that are going to give me a quality of life.
I'm 87 years old.
Bingo. Exactly. Because what happens, on television, we do a terrible disservice to ourselves. Television shows people getting CPR. They get up and go play golf. That almost never happens. I mean, I would say never, but that's not something you want to say. Almost never happens. In reality, something like 3% of people who have cardiopulmonary resuscitation don't have a better life. I mean, 3% have a better than dead. But, back to where they were. Never better than back to where they were. But most of them have a lesser quality of life. It's heartbreaking. So if that's electronic, even better, because now that lady's at church without her paperwork, but there's an EMT standing by who says, okay, this lady has a driver's license, and I'm going to put her information in here, and her name is Harriet Gould, and it looks like her birthday is, she's got a do not resuscitate order. Stop everything.
Okay, so that's how they're doing it, is through the driver's license.
Well, maybe. If the patient is able to speak, if someone is there with them to give the name, if what we're proposing is maybe a discreet little bracelet with a QR code on it, so that can be known.
Now, how would that be administered by, when she goes into the doctor's office for an annual checkup? He, at a certain age, would say, you need to go through this form, tell us what you want, we're going to put that in a little bracelet on your wrist.
Would you like to write a letter of support? Because you described that very well, and this lady and I are writing a grant to try to do exactly that.
Because I just turned 60, I'm starting to look at these things now.
Yes, and well, we should. When post forms were first used, I'm going to steal all her thunder. People were told, if you're within 6 months of death, you should fill out a post form. Do you know exactly when that is? If I knew I was going to die in 6 months, I'd fill one out, but I don't know that. So that's been loosened, and it's been people with serious illness, people with serious chronic illness whose doctor would not be surprised if in a year they had died, and people over a certain age. Those of us who are 60 are saying, oh, that's not the age. It must be up here someplace.
Yeah, 10 years ago, you'd have said 60.
I would have. And my younger sister keeps reminding me that I said that. So, you're right. Everybody should do it. Are you waving?
There's some risk in that, though, going electronic. There's something reassuring about seeing that piece of paper with a signature on it versus electronic feedback that, let's face it, there could be some misidentification of the individual. There could be some confusion when she was completing the form. Something that, okay, now we're going to withhold some service based on this information. Maybe it's not right.
You're absolutely right. Now, go ahead.
The way we have modeled it is you can actually print out a Word form. So you look at the electronic version of it, but then you can print it out and there's the patient signature. So the workflow is where the provider would have a conversation with the patient, fill out the post form electronically and actually print out the form, get the patient to sign, he would sign, and then they would somehow scan it. But then it would just improve access to the EMS providers.
Good.
So to have that patient verification, you could look at the post form and say, okay, this is the signature, this is the name, and they would take that later.
Right, and I think that's good, as long as whatever generates that form for them to sign is exactly the same process that EMT is going to follow.
Exactly.
Yes.
Well, okay, here's, yeah.
A little problem on that is that my wife is one of those 3%. In fact, she was revived from a flatline 3
and back to the
It's
same
been
level
2
as before.
months of pain at
Oh.
your chest. And during that 2 months of pain, she says, I don't ever want to be resuscitated again. Now, it's a year and a half later. She feels pretty good.
Yep.
Yes, that's one of the things. So the pulse form is, it basically is required to document the patient's preferences at that period of time. So if you change your mind 2 years ago, you
You have
get
to remember
married,
to
you
pull
have a
it out.
grandchild, you want to live
Yeah.
longer, they would change the pulse form.
Yeah, you have to remember to do
Yes.
that.
It's a conversation that should keep going. But you know what's more important than the paper form? It's the fact that, John, you know what Marcia wants. I don't know their name's Marcia, I made that up. But John and Marcia, I don't know, works for me. You know what she wants. You two have had the conversation. And so you know. So if you guys are out strolling on the beach and she goes down, you know, yesterday she said to you, I'd go through that again. If it meant I could have another 2 years, I'd go through that again. You can say when the EMTs come, do everything you can to revive her.
Even though the form that she had signed says the opposite,
Well,
that's electronic.
let me back up a little bit and just say that when you have that conversation, please go change the form.
Well, if it came.
But oh, by the
they would
way.
probably go along with the one who said.
The living.
If the husband, yeah,
Yeah.
exactly.
Yeah.
And that's a problem, because guess what? My 87-year-old mother-in-law lives with me. She has told me she doesn't want to be resuscitated. However, if we've filled out the form, but it's never been signed, because it has to be signed by the doctor. So if the EMT comes and there's not a signed form and I say she doesn't want it, they're going to go,
Say, it's your mother-in-law. You're only saying that because it's your mother-in-law. I would say.
that's kind of cynical.
You think?
But you're right. You're right. And so guess what I did? I said to my husband, I don't think I should witness this. Because nobody will believe, whatever I say. So, yes. So, any other questions? Yes.
I have a question about sharing this information. When we first moved to Utah 30 years ago, we were with the University of Utah Health Network,
Mm-hmm.
had our information
Mm-hmm.
for about 12 years, and they moved.
Mm-hmm.
And we changed
Mhm.
to the IHA. Now we're back at the University of Utah, and there's a gap. We go there and we look at our health records. They don't have what we did during the years we were in IHA. And what I want to know is, what do we do about that?
Well, okay.
Should that be the case? And if it should be, where do I go to fix it?
I'm sorry that Wyatt left, because let me just tell you how you fix that. Okay, number one.
He'll be back.
Yeah, he'll be back, and that's what he's going to talk about. But when you were with the University of Utah system, anything you had done in that system, they could find. When you moved, anything you had done in that system, they could find, but they couldn't look at that. And then you moved, and this guy might be able to look at this one, but probably not this one. So you have a fragmented record all over the place. And oh, by the way, sometime in there you went to Moab, and you had some testing done at the hospital down there, and that's not available to anybody. Well, Wyatt's going to talk about electronic health records. And the Health Information Exchange is a data warehouse that the University of Utah makes its records accessible to. IHA makes their records accessible so that your doctor now, oh, so does Moab Hospital, by the way. So your doctor now can say, whoa, in 1972, you were in the University Hospital for gout. And, oh, but in 1982, I see that you had this test and your gout had not recurred. So all of that information can be accessible to your provider if you agree to let your provider have access to your information. But to do that, it doesn't go into the warehouse until you say, I want my data to go into the warehouse.
Do I go to say?
I wish I had forms.
And Wyatt, are you going to stay? Because Wyatt's going to talk about that.
So I'll write it up here, but it's mychi.org. And that's where you can go to sign that form. And if you have an Intermountain Healthcare physician, they have that on their website. If you have a University of Utah physician, they have that on their website. and it's possible to go do it. Some offices, you know, that dreaded paper form I talked about, some offices do it in paper and then get it put into the system. But if you're in that system, you've approved your stuff to be in there, and your provider does what they're supposed to and puts it in, then any provider, that guy down in Moab, can look at all those records and know what to do with you. Oh, by the way, not just anybody can look at your stuff, though. Only the doctor that you authorized or has a reason to look at that, because if they do, DOPL, which is the Division of Professional Licensing, will come after them and drag them out. So I think I'm done here because it's no longer my turn. Oh, gosh.
Open for question and answers.
Well, oh, yeah, question and answers. I forgot that, didn't I? Actually, I was so worried about going over time because I have a real tendency to talk too much that I gave myself a timer with less time than I was supposed to use so that I would maybe be efficient. And for the first time in my life, I was efficient. So unless there's another question, we can move on to another exciting topic. And thank you